but we really appreciate you for accepting our invitation.
Oh, my pleasure.
And this is like a very good learning experience for us because we are so trapped with all these challenges around us. So, okay, let me just, it's already 9 o'clock, so I would like to welcome everyone. Welcome. We have so many attendees today from different parts of the world. We have from Indonesia, we have from India, we have from Taiwan, Malaysia, the United States. We have from different countries from the Middle East. I do not know exactly where they were. Some are from Saudi Arabia, Pakistan, Iran. So also Thailand. Thailand. Some are coming from Thailand. So I kind of remember their names. And we just would like to welcome you. And today we are so privileged to have Dr. Jon Jacobson, who doesn't really need a lot of introduction because everybody knows him. Okay, Stanley Lam is here from Hong Kong, and welcome, Stan. And so we are so happy that we can do something different in spite of the challenges around us. But before we begin listening to Dr. Jon, uh, as I don't want to waste a lot of time to be giving an introduction to him, I would like to ask everyone to please pause for a moment and let's just have a short word of prayer. Let's pray. Heavenly Father, today we are so grateful. We are so thankful for life that you've given us, for preserving, Lord, our lives, and you have given us the opportunity to learn today from Dr. John. And we entrust, Lord, to you his lecture that may we learn from him today and be able to apply it to our patients and be able, Lord, to also experience your grace and your goodness today. We ask, Lord, for the forgiveness of our sins. And for the rest of those who are attending, may you give your presence to us. In Jesus' name we pray. Amen. So again, welcome. Dr. John, I'm going to turn over the hosting to you so you can now control everything. You're the host now, and so you can manipulate the screen as you wish. So welcome, Dr. Jon Jacobson.
All right. So thank you, everyone, for tuning in. I know it's 9 in the morning there. It's 9 p.m. here. I'll be talking about ultrasound of the post-operative shoulder. That topic can be very challenging, and I know that many of you are quite experienced, so I thought it was an ideal topic to bring to the table. Now, I'd like to keep this informal as much as I can, even though we're digital and remote and virtual. So I know that there's a chat room where I can see things, but when I'm giving the lecture, it's hard for me to go back and forth to the chat room. So I'll look at the chat room at the end of the lectures, but during the lectures, please feel free to interrupt and ask a question as we go along, and I can clarify points. Does that sound okay? All right.
All right. Yes, Dr. John.
Yes. Yes, Dr. John, clear.
All right. So I'm going to share my screen and bring up my PowerPoint, and I hope this works okay. Now, can you see my title slide okay?
Yes, clearly.
Okay. And is there anything in the way of the screen? Meaning, is there any black boxes that are causing issues, or?
Not at all.
Not at all. So
Okay, good.
you're good
Then
to go.
I will continue. So ultrasound of the postoperative shoulder. Okay, disclosures. I'm a consultant for BioClinic, advisory board for Philips, book royalties from Elsevier. Not relevant to the talk. So this is what the outline or the objectives will be. I want to mention that this talk in PDF form I just uploaded onto my website where I keep all my syllabus material. So you can go to that, download it, delete it, whatever. But you can refer to the lecture in PDF form by downloading it. All right, so the primary objective is to understand the appearances of the rotator cuff after rotator cuff repair, and to recognize specifically when you have re-tears of the repaired tendon. And then at the end of the talk, I'll be talking about biceps tenodesis and then how to assess the shoulder after a joint replacement. And can you see my mouse moving?
Yes, yes, yes. We can see it. Yeah.
Okay, good. All right, so the first part of this talk will be about rotator cuff repair. Okay, the first thing to understand is that there are different ways the rotator cuff can be repaired. It's important to understand which surgery was performed because this will determine what possible complications can exist. At least in the United States, arthroscopy is by far the most common approach to repairing the rotator cuff. Open surgery is still performed. Realize that when there is open surgery, this involves deltoid detachment and reattachment. So an added complication after an open surgery would be a problem with the deltoid or dehiscence or something wrong with the deltoid itself. Then there's something called the mini open, where it's a combination where they have a small surgical access where they split the deltoid, but not necessarily detach it completely. And it's assisted with arthroscopy. So it's a combination of both. So it's important to understand which surgery was performed. Also, it's important to understand the pathology that you see prior to the surgery will help determine how the surgeon repairs the abnormality. And then that will determine what you look at after the repair at imaging. So for example, if you have a underlying partial tear of the supraspinatus, if it's less than 50% articular or bursal, most commonly the tendon is debrided. So in that scenario, you would not necessarily see suture anchors or changes in the bone from reattachment. It's just basically kind of cleaning up the area, including usually resection of the bursa. Now, if you have a larger, or I should say deeper articular sided tear, commonly this will either be repaired or converted to a full thickness tear and then reattached. So realize when you're looking after surgery, if you look at the imaging before surgery, you can somewhat predict what surgery was performed. Now, if they have a full thickness tear or they've created one, that's where they need to reattach the tendon to the bone. This could be done in two different forms. A transosseous fixation with the trough is usually what occurs. You can have sutures going through the bone where they're actually the sutures are tied at the lateral part of the greater tuberosity. But more commonly, they put suture anchors into the greater tuberosity itself, and they simply tie down the tendon with suture material to those anchors. So a trough with direct opposition with suture anchors, at least in the United States, is the most common approach. Now, when you look at the suture anchors, they can be metal, plastic, or bioabsorbable. And also when they install or attach these suture anchors, it could be a single row, multiple or double row in various configurations. By far the most common, at least in the United States, is the double row technique. And I'll show you what that looks like. So if you look at the anatomy of the greater tuberosity, we know that the rotator cuff doesn't normally come down to a point and attach to the greater tuberosity. It really covers a broad attachment, or what we call the footprint of the greater tuberosity. So a double row technique, as shown here, you have one row at the articular surface of the supraspinatus and another row more distally in the greater tuberosity. So this double row fixation more simulates what occurs normally or anatomically. A single row, of course, is probably less strong and it's less anatomic. And that's why, at least in my experience, this is the most common scenario. The double row suture anchor with a trough and direct opposition of the tendon. You can see the suture material tying that tendon to those suture anchors, opposing the tendon to the trough. Now, as what's indicated here, Most commonly, of course, we know the supraspinatus is the tendon that's commonly torn, and it usually occurs at the footprint. So they basically want to reattach it to that greater tuberosity footprint. Now also realize that in addition to attaching the rotator cuff, they're going to either debride or resect the bursa, the subacromial subdeltoid bursa. So you'll see after surgery that there's typically thickened hypoechoic tissue between the deltoid and the repaired supraspinatus. Now we can't call that bursitis in every case because first of all, the bursa may be completely removed. And just because there's thickened tissue there doesn't mean it's inflamed. It doesn't necessarily warrant an injection of steroids. So what I typically do is when I see that finding, which is common, I just describe it as thickening or hypoechoic tissue in the region of the subacromial subdeltoid bursa. Now, of course, if you have access to the surgical report, or you could talk to the surgeon, then you can say, you know, was the bursa resected or not? Because then you could be more specific on what you see at imaging. Now, also because many rotator cuff tears are related to subacromial impingement, many times there'll be surgery to the AC joint and the adjacent clavicle. Now, when they resect the underlying bone spur or an inferior AC joint osteophyte, you really can't see those findings on ultrasound. Of course, you can see them on MR and radiography. Similarly, the coracoacromial ligament release, sometimes it's hard to make that out because of the hypoechoic postoperative appearance in the rotator interval. So that can be difficult. Now, if they decide to resect the distal clavicle, which is called the Mumford procedure, that's when you'll see widening of the AC joint, not because of trauma to the joint, but because the clavicle has been resected. So that is a finding you can easily see when imaging after a rotator cuff repair.
Yeah.
Okay, are there any questions? Okay, I'll keep going here.
Ini aja deh, beli buah aja deh.
Okay,
Jus aja
so
deh.
I'm hearing voices and they're not in my head, so maybe someone could mute the microphone.
Ya, sama.
Anyways,
Sorry.
back to the lecture here. So what about after the repaired rotator cuff? Now the problem is after it's repaired, it can be variable in echogenicity, it can be quite heterogeneous and quite variable in thickness. So all the indirect signs that we use to diagnose a native cuff tear, most of them cannot be used here. For example, thinning of the tendon, we can't use. Cartilage interface sign, we can't use. Cortical irregularity of the greater tuberosity, very common finding with a rotator cuff tear, we can't use because most of the time the surgeon has decorticated that tuberosity and it looks irregular in everybody. So that's what the reimplantation trough will look like, where there will be a defect in that greater tuberosity, where the tendon will be reattached with suture anchors, and you'll see these suture anchors and the suture material on the ultrasound image. So here are 3 different cases of an intact postoperative supraspinatus. I've included MRI, some fluid-sensitive sequences for those of you who are familiar with MR as a correlation. These are the same patients who've had the MR and the ultrasound. So if you look here on this long axis view, we see these hypoechoic areas. We see cortical irregularity. This is probably the attachment site. Note that there's a triangular area of a defect at the outer part of the tuberosity. Now, if this were a native cuff, I would have called this tendinosis and a partial bursal sided tear. But basically, when they reattached the tendon, they couldn't stretch it all the way over out to here. Or maybe this was a single row technique. So we can't call that a defect. What we see here is that although it's heterogeneous, the tendon is still attached to its attachment site where the bone anchor is. And here we see the artifact from the suture anchor. Now in short axis, we can appreciate the heterogeneity of the supraspinatus. Is this tendinosis? I have no idea. We're just going to call it postoperative change. And in fact, what I'm trying to decide, is there an obvious defect to call re-tear? Otherwise, I'm just going to discount these findings as being non-specific. Also note the volume loss or thinning of the tendon here. Normally that is an important indirect sign. Can't use that here after the cuff is repaired. On the MR, we see abnormal intermediate signal throughout. But the point here is we don't see an obvious defect of the supraspinatus. Here's case number 2 of an intact supraspinatus. In this case, we see again a heterogeneous appearance of the tendon. It's hypoechoic. We see this defect here, but what we see is this is the entrance site of the suture anchor. In fact, we see suture material going into it and more suture material coming this way. You'll often see a tram track appearance related to the suture material. So although this looks really unusual, we note here that the tendon is still attaching to the bone where the suture anchor and the sutures are located. And here on the MRI, we can see abnormally thickened intermediate signal, but still attached to the footprint. If we look in short axis, we can really appreciate the suture material going into the decorticated place where the suture anchor is located. Note all the heterogeneity, the hypoechoic appearance, and the volume loss, all non-specific findings. The key again, there's no well-defined defect. Here's a third intact supraspinatus. In this case, we really can see the reimplantation trough. The tendon is markedly thin, but it looks fairly echogenic, minimally hypoechoic. Again, we would report that there's no obvious defect. Note the thickened tissue out here in the region of the subacromial subdeltoid bursa. Now, if you look at this case, you see this echogenic material outside of the grade tuberosity. This is likely one of those transosseous sutures that come through and are tied over here. So that's what this appearance can indicate. And here in short axis, we see marked thinning of the tendon. Again, an important indirect sign with the native cuff of a cuff tear, but not after surgery. This is an intact tendon without a tendon defect. So here are just reiterating just different appearances and the variable appearances of intact and repaired supraspinatus tendons. You can see suture material, all the findings I've already talked about, just so you get an idea globally how heterogeneous this appearance can be. Now, if you see reverberation artifact, some of the older suture anchors will be metallic, or even some of the newer ones. It just surgeons have their own preferences for the type of suture anchors, but the reverberation can be explained by the smooth metal surface of one of the wings here, where the suture is connected at the suture anchor. Okay, so how about an abnormal condition? Well, we're going to look for a recurrent rotator cuff tear. Also be aware that with open surgery, where they go through and they actually detach and reattach the deltoid, it could detach, and you're going to look for that on ultrasound. Of course, with any intervention, including surgery, we'd be worried about abscess and any kind of infection, septic joint, for example, infection of the bursa. So that can occur as well. All right, so regarding recurrent rotator cuff tears, how well does ultrasound perform? As you see here, these numbers look really quite good. Accuracy of 94%. That number is really good. I don't believe I have 94% accuracy. Well, actually, I know I don't. We looked at a study and we were just around 90%. In my mind, if I can get over 90% in these tough cases, I feel pretty good. So, but you can get higher than 90% according to this paper here. Now, one thing, some points that were mentioned in these papers is that if you have a tendon defect, even at 1 year, it can actually heal and go away. Defects, however, tend to increase in size, and the strength of the patient may decrease, although they may be otherwise asymptomatic. What is interesting is that the structural integrity of that tendon does not necessarily correlate with pain or function. So not only are we struggling to make the diagnosis of a re-tear, we're not sure what this means to the patient in the way of pain or function. Although we know that a larger defect will have decreased strength. All right, so how do we diagnose a recurrent tear? Well, basically, we're looking for a defined tendon defect. Of course, the larger the tear, the more confident we will be in the diagnosis. Ultrasound will show that this defect tends to fill with anechoic fluid or hypoechoic synovial hypertrophy or debris or hemorrhage. This abnormality will be bright on a fluid-sensitive MR sequence. If it's completely retracted, of course, it will be under the acromion. You won't be able to see it. But the tendon retraction is a key finding. Another key finding, which I'll describe in just a moment, would be when you have suture material that's not within tendon, meaning that it's exposed. That either means the tendon pulled off of the suture or the suture pulled out of the tendon. I'll get to that in just a moment. All right, so here's an example with MR correlation. So usually what I recommend is when you're looking at the supraspinatus, try to identify where the reattachment site is, because we know that typically the entire tendon does not cover the entire footprint after a repair. So this is where the tendon should be attached. I'm looking for a defect from here to here, and in fact, that's the defect. And we can see that also on the MR image. The retraction here is the key. But for me, there's no identifiable tendon between here and the implantation site. Okay, here's a second case with a re-tear with MR correlation. I'll note here on the MRI, this is a bioabsorbable suture anchor. That's why there's no artifact here. And this is where the suture anchor is coming out of the reimplantation site. So this is where I want to identify where the tendon should be attached. When I look from here to here, I don't see normal tendon at all. We see fluid. Here's some suture material floating in the fluid. I don't know what this is. It's either hemorrhage or synovial hypertrophy. It doesn't look like normal tendon, but even if it were normal tendon, there's a defect here. In fact, we look on the MR, maybe some of that is tendon, but the point is there is an obvious defect here. We want to confirm this in two planes, like everything in ultrasound. Here we can see this fluid-filled defect. And look at these exposed sutures here. So again, that is a very important indirect sign, implying here the tendon pulled away from the bone and left the sutures behind. The sutures really should be in the tendon and not just separate from them. That is an indirect sign of a recurrent tear. Here's another example with MR correlation. Again, we first look at the footprint and decide where the reimplantation trough is and see if we see any normal tendon connected here. I see tendon, I think, here, but the point is I don't see any tendon from here to here. In fact, that's the suture material where the tendon should reside. And if we look in short axis, again, that's the suture material, and there's no tendon associated with it. So this is an obvious defect here filled with fluid on the fluid-sensitive MR. Long axis here in coronal MR, short axis here on ultrasound, in the sagittal or sagittal oblique MR. All right, so now that you're familiar with the repaired rotator cuff without a re-tear and the examples of re-tears, there are some questions that come to mind. First of all, how does the repaired tendon appear at specific time points after surgery? And how does this change over time? And when should the tendon appear, quote, normal or relatively normal? So these next set of images are from a study we published years ago where we had 30 cases where I scanned the shoulder at several time points after surgery. I scanned the patient at day 2, week 2, 2 months, 3 months, 6 months, 9 months, 1 year, 3 year. It was a very interesting study. It took forever, as you can see, but it allowed me to check these cases in progress to see what was happening with the findings. So let me share with you the results of that study. So here we see after 2 weeks, a heterogeneous appearance. There's the reimplantation site. And you would look at this and say, is it interstitial tearing? Is it a defect? I'm not quite sure, but let's see what happens over time. At 6 weeks, it starts to fill in with tissue. At 3 months, it's starting to become more acogenic. There's that suture material. Now at 9 months, it's really starting to look linear and fibrillar. A little hypoechoic here, and then more acogenic at 3 years. So early on, it looked really like a defect, but it filled in. So what we had found is that within the first 3 months after surgery, that's when most re-tears tended to occur. They tended to occur at the bone attachment. However, we found that the abnormalities in the first 3 months, many of them actually improved over time. So the teaching point there is that if you see a defect in the first 3 months, we're not sure what's going to happen with that. Now, of course, if it's a humongous defect with retraction, that might be enough reason to say, well, maybe you should re-repair that, because I doubt something that large would actually fill in. However, again, the patient still may be asymptomatic. So the point is, when I see something that looks unusual in the first 3 months, I'll describe it, but I'll say it's unclear of the significance. But after about 6 to 9 months, then I expect it to actually look relatively more normal, meaning more acogenic. Okay, here's the second of 2 cases where we tracked this over 3 years. At 2 days, it just looks like a hypoechoic tendon, and there's the suture anchor. At 6 weeks, it's quite irregular at the surface, but I still see tendon going into the reimplantation trough. At 3 months, it's starting to organize a little bit better. Now, finally, at 6 months, it's starting to look like normal tendon. And at 1 year, it looks the same, and 3 years, a little bit better. So again, that was the trend, is that in the first 3 months, things really looked unusual, and many of them improved over time. So most tears within 3 months. Usually by 6 to 9 months is when things started to look relatively normal, meaning a little bit more acogenic. Any focal defect that you see, especially early on, maybe it's really non-specific, and who knows what's going to happen with that. Recurrent tears tend to be larger or get larger. So that is why, if you're not sure if something that's heterogeneous is a tear, especially when it's early on in the time course, get a follow-up ultrasound. I know my surgeons are not very thrilled to go back in and re-repair a tendon unless they're 100% certain it requires another surgery. So often, if I'm not sure, or if there's a small defect that might actually heal, we'll get a follow-up ultrasound in 3 to 6 months and see if it declares itself and gets larger, or if it actually stays the same or maybe improves. So the idea here is to be very conservative with the ultrasound reporting and consider following up any scan. And then I come back to this point, which I made earlier. Even if the patient's tendons were completely normal, they can be completely symptomatic. And then people with recurrent large tears may be completely asymptomatic, although they may be weaker. And we know larger tears tend to be more symptomatic. So even though we're trying to sort out what we see at the imaging, the clinician or you would have to determine what is the significance in the big picture in the way of symptoms, patient age, other comorbidities, and weakness. Does it warrant an additional repair or re-repair? So just to wrap up this topic of recurrent tears, I just want to show a couple other cases showing the importance of radiography. I'm still a fan of radiography because it's accessible, it's inexpensive, and it really adds tremendous information many of the times to ultrasound and to MRI. Many times it doesn't, but you'll see a case like this, for example, where we see the trough, we see tendon coming in. This was actually an anisotropy, but we see these echogenic areas. And what is that? Is it calcification? Is it cortical irregularity where they perhaps performed a bone spur resection? But if you look at the radiograph, you can see what's going on. This is actually the suture anchor that's pulled off. So even though it looks like there's tendon here, the fact that the suture anchor is pulled away tells me there is some re-tearing that's occurred here. Maybe the defect isn't really just presenting itself yet because it's filled with granulation tissue. So this could be called calcification and be completely incorrect. By the way, I've never seen calcific tendonitis form after a rotator cuff repair. So always consider the radiograph, especially if you see something echogenic on the ultrasound. Here's a companion case. You look at this thing and you see this horizontal echogenic area with maybe some reverberation. It's hard to decide, well, what is that thing? Did someone leave an instrument behind? Well, this, as you can see on the radiograph, is another suture anchor that's pulled out and is laying here. And therefore, this is a re-tear because of that. So don't forget the radiograph to correlate with any echogenic finding on ultrasound. When I'm interpreting an ultrasound or going in to scan a patient, the first thing I do is I try to see, is there a radiograph? Is there an MR? I try to get as much information as I can before I walk into the room so I don't run into these type of pitfalls. As we leave the rotator cuff repair category of this talk, I mentioned infection is a possibility, and so is this entity. It's called gossipiboma. Basically, it's a retained surgical sponge or cotton. It's been called also a textiloma. The word gossipiboma is an unusual term. It's a combination of a Latin term for cotton, which is cassipium, and the Swahili boma, which means place of concealment. So it's a Latin Swahili word called gossipiboma. So when you see this on ultrasound, and they look the same everywhere in the body, you look at this and you see this unusual echogenic area with these tiny ring down artifacts. Now, if I didn't have a history, I would have said, this looks like gas within the soft tissues. My first thought would have been an abscess with a hypoechoic rim and gas within it. But this is actually gas within this retained sponge. Now, this was infected as well. So just be aware of the unusual appearance. So when you have someone who's had any kind of surgery and you see this speckled ring down artifact, think about abscess, number one, but think about retained foreign body. Now, if we had a radiograph, the sponges that are used in the OR in the United States, I presume everywhere, have a radiopaque edge to it. So you would have seen that on a radiograph very easily. We didn't have a radiograph at the time of the ultrasound. Now, if you're interpreting the MR, it is a very similar confusing picture, meaning we see this heterogeneous area with tiny black dots, and that would raise concern for gas, like an abscess. Here's the peripheral enhancement after intravenous gadolinium. So this was basically a retained sponge with secondary infection. Now, if they're not infected, these can remain silent for years, and they can produce symptoms that can appear like a malignancy. And even at times on MR, you look at this, and if the black dots are not seen well, it can almost look like a sarcoma. So there are tremendous pitfalls when there's a retained surgical sponge. The problem is because they're not very common, we don't always have them on our radar as a possible finding to explain the features on ultrasound and MR. Okay, any questions on rotator cuff repair? Okay, the latter part of this talk, sorry, go ahead.
Yes, go ahead.
Okay, so the latter part of this talk is a little bit shorter, and we'll start with the second of three categories dealing with the biceps. So I'm talking specifically at the long head of the biceps brachii. Obviously, the biceps is two heads, the short head from the coracoid process, the long head from the superior labrum and the supraglenoid tubercle. These combine to form the muscle attaching to the radial tuberosity. So the mechanics or biomechanics of the long head of biceps brachii are unclear and often discussed, but people feel that it helps to stabilize the shoulder by depressing the humeral head. Now, if you have abnormalities of the long head of biceps tendon, such as a tear or tendinopathy, it indeed can cause symptoms due to the sensory sympathetic fibers. And that pain typically is referred to the anterior shoulder and palpable in the bicipital groove. So that is the features of biceps long head tendinopathy. And there's a host of imaging findings that we can see in the elongated biceps, like any tendon in the body, tendinosis, tear. You can have subluxation, where it's partly out of its groove, dislocation if it's completely out of its groove. Now, one problem is people with symptoms referable to the biceps brachii longhead tendon may also have symptoms referable to a slap or labral tear, an anterior cuff tear. So sometimes it's confusing. Is the pain generated truly from the biceps, or is it more proximal? Nonetheless, at the time of the rotator cuff repair, they may choose to perform surgery, or they may do this without a rotator cuff repair if there's no rotator cuff tear. Often, conservative management is tried first with NSAIDs, physical therapy. Injecting the tendon sheath is something that's fairly common. Now, you have to realize that the tendon sheath of the biceps brachii tendon, long head, connects to the glenohumeral joint in everybody. So if you put the needle into the tendon sheath of the biceps brachii long head tendon, and if you, let's say, hit 4 or 5 ml, that is going to go into the shoulder joint. Now, if you're simply treating shoulder symptoms, that's a good thing. It's 2 for 1. You're anesthetizing and treating the biceps tendon and the intra-articular structures. However, if you're doing the injection for a diagnostic purpose to see if they have pain relief just from the biceps, you want to go with a small amount of injection. So you're only treating, anesthetizing the biceps tendon and not inside the joint. All right, so if surgery is performed, they do what's called a tenotomy, where they resect or cut, or transect is probably the best term, transect the tendon near the labrum. Now, when they do this procedure, the muscle will cause the tendon to retract distally. They may or may not choose to use or perform a tenodesis, where they would tack down this biceps tendon anywhere there's variable sites in the bicipital groove. It can be more proximal, the level of the intertubercular groove, or it could be more distally near the pectoralis. What has been shown is that if you perform a tenodesis, when you tack down the transected tendon, it has a better appearance or improved cosmesis. Although there's still debate, do you really need to tack down the tendon in the bicipital groove or not? Probably depends on the patient's age, possibly surgeon's preference as well. All right, so what does this look like? So by ultrasound, if you look in the long axis, you'll have absence of the tendon proximally, and that's where it was transected, and the tendon will be seen retracted distally. Now, in this case, they performed the tenodesis. You see where the suture material is connected to the intertubercular groove. Now, there is a pitfall here. If you had no history of a tenodesis, this could be mistaken for an intra-articular body. Remember that a body in the glenohumeral joint will freely float into the biceps long head tendon sheath, and it can be mineralized and look just like this. Now, I've never seen calcific tendonitis of the biceps tendon itself, but I would have wondered about perhaps a bone spur from the lesser tuberosity or an intra-articular body. But just don't forget, this could be tenodesis. Now, the clue to that diagnosis is the fact that you don't see the tendon more proximally, and we only see it distally. Now, of course, if there's no tenodesis, but rather only the tenotomy, this won't be here, and the tendon will just kind of reappear. It'll be actually retracted more distally, similar to what you would see with a biceps tendon tear, a native tear. Now, here's a case of a failed tenodesis. Now, I've turned the MRI to simulate the ultrasound. So this is the rotator interval shadowing at the torn tendon stump next to the short head. This could simulate that. So again, if you see something echogenic, think about perhaps this failed tenodesis as a cause for this appearance on ultrasound. So here's a pitfall I want to talk about. And this is a pitfall not only after a after a tenotomy, but also after a native biceps tendon tear. So let's talk about a native individual who's not had surgery. We've been in the situation where it said, please rule out or let's look for a biceps tear. And you look in the bicipital groove and you see these thin echogenic linear areas. Now this doesn't look like normal tendon. And I don't know about you, but many times I've struggled to convince myself, could that be the smallest tendon in the world? Could it be a partial tear? Or is that a full thickness tear? And if it is a full thickness tear, why does it have this appearance? Well, my teaching point here is if you have to convince yourself there's a tendon here, that means there's no tendon there. So how do we explain this thin linear echogenic area? So one thought process is that the tendon sheath could be collapsed on itself. But this is really, in my opinion, the most common reason for this pseudo biceps tendon. It's due to the aponeurotic expansion of the supraspinatus. This is a normal thin layer of tissue that lays right on top of where the biceps lives. Of course, this biceps has been torn and is not in view, it's retracted. So here is the echogenic area. So how can we sort this out? Well, recognize this pitfall. You can then look more proximally and say, okay, the biceps is completely missing in the rotator interval. And then you could look distally and see it retracted. So you put these pieces together and then you can convince yourself, yes, the biceps is torn and this is not the biceps. This is the aponeurotic expansion of the biceps. So here's a companion case. This is a normal individual who's had an MR arthrogram and an ultrasound. So if we go to the MRI first, you can see what looks like on this axial image, two biceps tendons. Now I have to tell you that the number of times I've seen a true biceps tendon split, it's been like, I can count on maybe two hands in 20 years. It is very, very uncommon. However, this aponeurotic expansion is present in half of the individuals. So it's not even really a normal variant. I almost consider it an expected finding. And the key is you see this linear structure that looks like the biceps sitting right on top of it, typically smaller. Now, if you follow this on the MRI, look what happens. The biceps goes to the anchor, meaning the labrum and the supraglenoid tubercle. But look at the aponeurotic expansion of the supraspinatus. Where does this go? It goes and connects to the supraspinatus, hence the term, the aponeurotic expansion of the supraspinatus. So if we get to the ultrasound, it almost often looks like a heterogeneous appearance. So we have the aponeurotic expansion sitting on top of the biceps. And if you look here in short axis, you can see the two different structures. Now, what I'm going to do on this video clip, I'm going to show you what happens when I rock the transducer. Because these two structures are going in slightly a different course, you have differential anisotropy, where the biceps goes from bright to dark and the aponeurotic expansion goes to bright to dark in a different fashion depending on how we're rocking the transducer. All right, so I know I've gone off on a tangent here, but I think this is an important pitfall when we talk about the biceps long head tendon. If you're looking for a tear, or in this context, a tenotomy, you want to decide, well, if there's a thin linear structure left behind, don't overcall that as the biceps tendon. If you have to convince yourself it's there, then it's not there. Okay, the final part of this talk, let's talk about shoulder replacement. So if you look at any joint replacement, there are really two general categories. There's a total joint replacement or a partial or hemiarthroplasty. With a total shoulder arthroplasty, both sides of the articulation are resected and replaced. With regard to the shoulder, it would be the glenoid and the humeral head. With a hemiarthroplasty, just the humeral head is replaced. The point here is with both of these arthroplasties, the greater and lesser tuberosities are untouched. And that's where the cuff attaches. So our bone landmarks will persist. Now, it turns out in the shoulder, there's a relatively newer arthroplasty called a reverse total shoulder arthroplasty. Let me go right to the imaging and show you what I'm talking about. So first of all, here is a total shoulder arthroplasty. You can see the head and here's the stem. So the head is replaced and the glenoid on the other side is replaced. So both sides of the joint are replaced. That is a total, conventional total joint replacement. On these two examples, which are hemiarthroplasties, note that the humeral head is replaced. This is a resurfacing hemiarthroplasty. This is a conventional hemiarthroplasty. The glenoid is untouched. That's why it's hemiarthroplasty. But all three of these have one thing in common, and that is that the tuberosities are still there, the greater and the lesser. The greater, the lesser is superimposed here. But in contrast, look at this reverse total shoulder arthroplasty. It's a total shoulder arthroplasty because both sides of the joint are replaced. But look, it's reversed. Rather than the head being round, the glenoid is now round, and this is now flat. So why do they choose to do this? If you have a rotator cuff tear, they're not going to choose this. They're going to choose this. So my point is, if you're asked to look at an ultrasound after reverse total arthroplasty, you expect the supraspinatus to be completely torn, even without looking at the patient, because that's why they perform this arthroplasty. On the other hand, ultrasound is an ideal method here because the bone landmarks are still there. So we can approach this like any other native shoulder. So let me show you what I'm talking about. So here's an example of a total shoulder arthroplasty where both sides of the joint are replaced. And we can see, because it was not a reverse total, that the tuberosity is still present. So you would go through the ultrasound protocol like any other shoulder, where you see the rounded head, you see the shelf or the footprint of the tuberosity in the supraspinatus. Now, if you look here, this shows actually reverberation artifact. It looks just like the humeral head, but since it's replaced, it's brighter, it's smoother, and it has reverberation. And this is just a junction between the arthroplasty and the greater tuberosity. But basically, if you disregard this, it looks like any other rotator cuff assessment. Here's a companion case with a resurfacing hemiarthroplasty. The tuberosities are still present. Here's the greater tuberosity. This looks exactly like the humeral head, but there's more reverberation artifact telling me that this is metal and smooth. The rotator cuff is normal. This person has bursal distension. So the point here, it's treated like any other native rotator cuff. And in this case, there's high riding where the humeral head is abutting the acromion. So even on the radiograph, we'll expect that the rotator cuff is completely torn, and indeed there's the defect. Now, as we wrap up this talk, just a few final comments about an arthroplasty. So if we're putting an arthroplasty in, how do they get to the shoulder to resect the head? Well, they go through the subscapularis. So this is where the problem occurs. The surgeon goes through the subscapularis, does the arthroplasty, and then repairs it. And that can be a very problematic area to assess. So how do we approach this? Well, we approach it just like we talked about in the first part of this talk with the supraspinatus repair, meaning that it's going to look heterogeneous. You're going to see suture material. You'll see an implantation trough, perhaps. The point is you don't see a defect. So the irregularity, the heterogeneity, all that is really non-specific. This one has a fluid collection with suture material that is exposed. So just like in the supraspinatus, that would imply that this is a re-tear of the subscapularis. So be aware that this can be a problematic area to assess, but approach it just like the supraspinatus repair. And finally, the last slide of this talk. Here's a patient where these screws coming through after the arthroplasty were protruding, producing inflammation and irritation of the bursa. Remember, the subacromial subdeltoid bursa is a composite bursa. It's not only under the acromion, it tracks all the way underneath the deltoid beyond the tuberosity, and these areas were causing irritation. The patient would point to this, and you would put the transducer here to make this diagnosis. Here we can see the reverberation artifact and the fluid as these screws are poking into the bursa and the adjacent deltoid. All right, so take-home points here. Repaired rotator cuff. Most recurrent tears occur within 3 months at the bone reimplantation site. Everything that we see within 3 months are nonspecific. And some of what we see abnormally, what we think might be abnormal, could actually disappear and normalize after 6 months, or it could get larger. So be careful diagnosing anything under 3 months unless it's a large, obvious defect. But we expect the tendon to start to appear more normal by 6 to 9 months. I don't diagnose a re-tear unless there's an obvious defect. In fact, my reporting is very simple. I'll say there's expected post-surgical changes, might comment on thickening in the region of the bursa, but I'll say that there's no defined defect to suggest a recurrent tear. If there's something equivocal, say that there's an equivocal defect or questionable significance, especially if it's under 3 or 4 months, and then that's when the follow-up scan doesn't hurt because it can tell it may improve or it may declare itself and get worse. For a biceps longhead tendon, the tenotomy, they could perform a tenodesis with a suture anchor seen anywhere along the bicipital groove. I talked about the pitfall of any tear, or if there's a transection of the biceps with regard to the aponeurotic expansion of the supraspinatus. And finally, arthroplasty. Ultrasound really works great. Of course, CT, there's artifact MR as well. And when it's not the reverse total shoulder, all the tuberosities are present. So you simply approach this like a native shoulder. If it's reverse, then it's really a struggle. Well, first of all, the tendons are expected to be torn anyways. All the bone landmarks are gone because they've been resected. So we typically don't assess those very frequently. So the syllabus, as I mentioned, you can download that from my website. I put all my syllabi material. I want to thank everyone for tuning in and spending the last hour with me as I talked about this subject. I've visited Manila several times, and it's sad I couldn't be there in April, and I look forward to returning again and seeing you in person. And Jim, I want to thank you for the invitation.
Yeah, thank you very much, Dr. Jan. You see, I think what you just lecture is the lecture that you're also including in your lecture last April, and I really appreciate your sharing with us this very comprehensive discussion on the shoulder post surgically, and we know this is one field that we are not so. I mean, we need a lot of information and a lot of skill, and what you just showed us is something that could be very useful for our practice, and hopefully we can apply some of those, although not really adequately at this point. But I have two questions for you, Dr. John. My first question is when, of course, I don't know if some of us would participate in the pre-surgical meeting with the surgeon, and that would mean would the ratio of infraspinatus to teres minor would still be important in deciding whether this particular surgery should be pursued or not. I heard a lot of people saying that the infraspinatus teres minor ratio should be 2:1. So would that be a surgeon's to decide, let's say they ask our opinion about whether these patients would benefit from surgery or not?
Yeah, so Jim, good point. The surgeons, from an imaging perspective, will take into account the extent and size and especially the retraction of the tear, but they will want to know about the status of the rotator cuff musculature. And since the teres minor is normal in 96% of shoulders, that's often a great intrinsic standard. Now, what they're specifically looking for is fatty infiltration, and then later on, when it's small in size, atrophy of the infraspinatus and the supraspinatus. Now, we know that MR is an ideal test to look for atrophy and for fatty infiltration. In fact, it probably outperforms ultrasound. But when you have extensive fatty infiltration and atrophy, ultrasound works quite well. So I'd say the more extensive cases, I think I feel pretty confident. So I definitely report that and convey that to the surgeon. They'll take that into consideration with the size and retraction of the tear. But importantly, they'll put together that with the physical findings and the history and the symptoms of the patient and put all those points together.
I see. Okay, thank you, Dr. Jan. And my second question is, uh, when you monitor the tendon post repair, uh, would there be a role for maybe elastography to guide you see the status of the tendons? Would this be a good thing that for us? Maybe some of the people here are doing that. I just don't know if this is useful for us.
Yeah, there's been some more advanced techniques looking at the post-op cuff, including contrast agents, and then elastography, first strain, and now other forms of elastography, shear wave, I should say. Now, what we've been trying to do was to assess the muscle to see if the early fatty infiltration will appear differently with the elastography. We found that somewhat difficult given the depth of the infraspinatus in some of these larger patients. So we didn't have a lot of luck, but people are pursuing that. Now, with regard to the tendon itself, uh, I believe there are some reports on that, but I can't pull up in my mind the author's name right now. But I can tell you that all these advanced techniques, I think people have been looking at, even with the contrast material, but really nothing has added significant, I guess, clinical value at this point. I think it's more of interest in research.
I see. Thank you, Dr. John. And we still have here a question from Dr. Mike. Would you like to ask this question directly, Mike, to Dr. John?
Hi, Dr. John. Thank you for
Hi.
a very great lecture as always. I do get a lot of post-surgical referrals. My question would be, do we still, how do we do the written report if we have, do we still describe the sutures, the anchors, the prosthesis, especially if the findings are normal or if we feel that the findings are equivocal? Thank you, Dr. John.
Yes, thank you for the question. I do report some of those findings, but I have to admit, as I practice medicine over the years, I'm trying to be more efficient. So unless I think it adds a lot of value, I probably don't go into a lot of detail. Now, if I see a finding that's unusual, then I'll really be more specific. But for example, I would say echogenic suture is noted with heterogeneity of the cuff and expected cortical irregularity of the tuberosity consistent with uh, post-surgical changes without a defect to suggest re-tear. That might be like bullet number one. And number two might be thickening of tissue in the region of the subacromial subdeltoid bursa without a defined fluid collection. I mean, that would be kind of a short report where I would describe it a little bit, but not go into tremendous detail. But again, if there's something unusual, then I would really spend more time on that. But that's my personal preference, where I tend to make my reports shorter because that way I can work faster, and that way people might read the report if it's shorter too.
Any more question with regard to the lecture, Dr. John? A lot of our attendees here, Dr. John, are doing regenerative thing. So maybe they just hesitate to ask this question, but um, would it help to do some injections post-surgically for symptomatic patients, maybe during the process of rehabilitation, because a lot also are physiatrists here. So we struggle on uh, maybe addressing the pain itself, and we might consider doing regenerative treatment. So what is your advice?
Yeah, so over the years, specifically PRP has been used either injecting or placed at the time of surgery, even with scaffolding, so that the PRP stays at the surgical site. And they're using other types of biologics now. And over the years, the results have gone from promising to it doesn't help. And the latest ones I've read said that it has an added value. And even there was a study that came out, I think, last year where they injected PRP into an interstitial tear and showed that it didn't help. So I would have to say that we still aren't sure of what is the best biologic, because I don't think we've tried everything. But I can say that specifically most has been done with PRP, and it's been variable over the years. There hasn't been one study that says this is what we need to do to improve outcomes. So I think the jury is still out on biologics and rotator cuff repair.
I see. Thank you very much for that. Melaine, you have a question? Go ahead. Melaine, Melaine, hello.
Yeah, here. Sorry.
Okay.
Thank you so much, Dr. Jacobson. Mine is not actually a question, though I would like to ask for your opinion. But this is regarding a surgery of the rotator cuff. We've had this case in my center and Dr. Ed Bionat's center, wherein the surgeon could not remember if he placed a bioabsorbable screw or a non-bioabsorbable screw when he did the repair of the full thickness tear of the supraspinatus. So the patient kept coming back to me because I was actually the one who referred this to a colleague, and then this colleague of mine referred the patient also for surgery. But then, like if I see the patient again this year, I think it would be 2 years and 6 months. So the last time I scanned him, it was already 2 years before the pandemic. And the patient is still not able to do a full shoulder flexion because on the ultrasound we can still see the full screw in its all in its complete length. You can see all the what you call that, the reverberations, and it's still complete. So then I had to insist to the surgeon that I could actually count the screws. I mean, how many spirals are there in the
Yeah.
screw? And then that's the only time that he was convinced, yeah, maybe it's not a bioabsorbable screw. And it's really impinging into the underneath the acromion. It goes into the greater tuberosity on the footplate of the supraspinatus. So I guess if I see the patient again after I return to the clinic, the patient would still have the same complaint that she's still unable to do a shoulder flexion. It's been 2 years and 6 months. So, any comment on that? What's your opinion on that, Dr. John?
Yeah, so if you can see the entire screw and count the threads, that implies it's pulled out, regardless of what it's made out of, and that usually implies that there's some failure of the fiber attachment. And in my experience, usually um, the surgeon will go in and take it out or reattach the tendon, especially if the patient is symptomatic. Now, to decide if it's metal or bioabsorbable, a radiograph would help with that. An MR would be over the top, but that would show it too. But the easiest would be a radiograph to see if it's metal or not. But my experience, when the screw's completely out of the bone, um, the ones I've seen, they have been symptomatic, although it could be sampling error. And in that case, they've all gone to surgery.
Thank you. Thank you, Dr. John.
You're welcome. Thanks for the question.
Okay, Mike, you have one more question here. Go ahead, Mike.
Hi,
Speak up,
Dr.
Mike.
John. In correlation to the question of Milane, if for example patients cannot undergo an MRI or an X-ray, are there any other suggested radiographic correlations that we can do for the patients? Thank you. Yes, that's correct. That's correct.
Yeah. Um, if the suture
Thank you.
Okay, thank you. Are there any more questions? We have surgeons here. We have a shoulder surgeon here. So why don't you speak up, guys? No questions? Okay, so thank you very much, Dr. John, for your time. I know it's late in the night in your area, and we just appreciate your very comprehensive lecture. It was new for a lot of us, and it's something that we need to learn more in the future. And hopefully by next year, Dr. John, if all this is over, the COVID is over, then we can resume our conference next year. And we're looking forward to having you again with Dr. Jeff. It's always nice to be with you and learn so many things. And this is just one part of that. And from the bottom of our hearts, from Asia and from other countries here, we would like to thank you so much for all this information that you have shared to us today. And hopefully you're safe too. Uh, make yourself safe because we'd like to see you next year.
Yeah, thank you, Jim, for the invite, and I'll be happy to give another lecture down the road if you need me to. I'd love to help, and then I look forward to seeing you and the others hopefully next year when hopefully I can come out to the Philippines again.
Yeah, thank you very much, Dr. John, and we will keep in touch with you. I know you will be reporting next week. Hopefully, we can find another time where we can discuss something else. So thank you very much, and be safe. Have a good day. Thank you, everyone, for coming, for attending, and take care. God
Thank
bless.
you. Thank you,
Thank you.
everyone.
Yeah, thank you, everyone.
Thanks for tuning in.
Thank you, Dr. John. Yeah.